চলো। হ্যাঁ,
ओम गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
ओम गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
ओम गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
Pallavi, can you play the ESI anthem? Pallavi, you there?
Yeah.
Amchite ma'am, link.
Okay. No, she has not joined yet.
No.
Madam, have you sent me the link on email? I have not received it.
hold on, Nirmala, I'm trying to send it. Just hold on.
Okay.
Let it start. I'll be sending it from my computer.
We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe we shall overcome someday. We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe we shall overcome someday. We'll walk hand in hand, we'll walk hand in hand, we'll walk hand in hand someday. Oh, deep in my heart, I do believe we shall overcome someday. We'll walk hand in hand, we'll walk hand in hand, we'll walk hand in hand someday. Oh, deep in my heart, I do believe we shall overcome someday.
Nirmala?
Yes,
Hello.
sir. Good afternoon, sir.
Nirmala, what is your...
Yes.
Nirmala, what is your... Yes, you can speak.
Should I continue?
What is your... yeah, you can continue.
Harshini, I
Yes,
think
ma'am.
Natasha madam has not joined.
Ma'am, she said she'll
Huh?
join in 5-10 minutes, ma'am. Maximum.
Okay. So, by the time Partha
Sir,
finishes.
yes, ma'am. Yes, ma'am.
Yeah.
Yes, ma'am.
So, let us not delay.
Good afternoon, everybody.
Good afternoon, madam.
Today we start with
Pallavi.
the 5th module of our program. Our first speaker is Dr. Partho Bhattacharya. He is very popular among all of us and needs no introduction. Madam, please, will you copies CV because I am with my phone only.
Yeah. So, well, Dr. Partha Bhattacharya is a medical specialist in Manikatla ESI Hospital, Kolkata. He's an associate professor in Lincoln University College, Kuala Lumpur, and examiner for MRCOG Part 3, secretary of Scientific Committee, Endo Society of India, and international publications. He has lots in BJOG, Journal of Pineal thing, and then International Urogynec Journal, Sri Lanka Journal, and International Critically Ill Journal, and so many things. And his special interest in is endometriosis and high risk obstetrics. We could have seen him working for all the conferences, ICE conferences, what has been conducted by the ESI. And I welcome Sir to deliver his first talk on there is
Dr. Partha.
over to Dr. Partha. He will be giving a talk on diagnosis and classification of adenomyosis, because adenomyosis is an important topic. It's though it is a part of endometriosis, I think we need to learn thoroughly about adenomyosis, because the problems caused for the woman during the reproductive age group is fertility, recurrent abortion, and so on, and near the perimenopausal age, it leads to severe dysmenorrhea and menorrhagia. So now let us hand over to Dr. Partha regarding the classification and the diagnosis of adenomyosis. Partha sir, please unmute, sir.
Okay,
Yes,
I think
you're
I'm audible
audible, sir,
now.
now.
Yeah.
Make it full
Um,
screen.
And good afternoon to everyone. Probably Sar is there online, I think, and Pradeep Da, Ramani Devi ma'am, Nirmala ma'am, and everyone. So it's a very basic thing to start with the adenomyosis, the classification and diagnosis. I am just yeah, now I can see the whole screen. Is the whole screen visible, I think?
Yes, it is visible, sir, now.
Okay, okay.
Visible.
So let me
Perfect.
start with a very practical, true story, and then I will go to the classification adenomyosis just to describe that what's the importance of this topic. Why are we spending this valuable half an hour on this topic? The kahani of a little girl, 18-year-old girl who was admitted in the general surgical ward with complaint of acute abdominal pain, and obviously she was all the investigation was done what was possible on the art, like EVG, CT, even endoscopy was done, nothing was found. And then they made a psychiatric referral, and then the psychiatrist discovered that probably she's suffering from conversion disorder, and some antidepressant was started. And now, while before discharge, someone come to mind that yes, a gynae referral could also be done just to complete the formalities. Yes, we have done all the possible referrals. And then I was called to the ward, and as I start from the very basic history, I discovered that she was actually having a regular dysmenorrhea and heavy menstrual bleeding, and this time this pain was so much unbearable that's why she resorted to the hospital, and she was admitted in the surgical ward because she was having a lower abdominal pain. So I transferred that girl to my own ward and arranged an MRI, and MRI showed a typical diagnosis of adenomyosis. She was only 18 years. Obviously, fortunately, there is no endometrioma or other evidence of endo. I am not going into a treatment because that is not my domain today. That I started this story because it is one of the commonest causes of the OPD attendance. It's everyone's experience, apart from in the gynae patients, not the obstetric patients, among the gynae patients. If we segregate the subfertility patients, I think almost 4/5 to 2/3 patients actually come who eventually end up with the diagnosis of adenomyosis. It's the commonest cause of AUB, which in our student is known as a DUB, because I remember those who are around my age, or even senior than that, my teachers are used to say they were very much restrictive about using the term adenomyosis, because in our textbooks, till I remember, it was written as adenomyosis endometriosis, a very small paragraph, is a disease of the affluent Western society. And that was the perspective in the late 90s or even in early this millennium. So DUB was the term. And that's why the delayed diagnosis, because of lack of awareness, not to speak about the patients, because our Indian women specifically, they take, yes, as a part of the womanhood, that a heavy menstrual bleeding, a period pain, all these things, just like endometriosis goes unnoticed. Lack of awareness on the part of our gynecologist too, and that actually lead a compromise, continuously progressive and continuous compromise of the quality of life. Heavy menstrual bleeding, pain that goes to anemia, that goes to dyspareunia. My very well-known cousin's wife, who is a professor of our college, actually fell while on the dais while taking a class, and then she discovered an anemia because of menorrhagia, and ultimately she was having adenomyosis. So this is the level of the compromise and unawareness. And most important is that increasingly occurring, these are everyone's experience, I'm sure, increasingly occurring in the young women and the girls. So what is the incidence? If we go to the incidence, it's very difficult to know actual incidence, but hysterectomy specimens show that there is 51 to 88% prevalence of the adenomyosis, but that is the obvious in a highly selected population, because this is only hysterectomized patients among the hysterectomy done for all the benign conditions. But in UK, there was a study in 2012. They showed that all women attending a gynae clinic, including symptomatic and asymptomatic adenomyosis, it was 20.9% in women. Then in Italy, they did a study in 18 to 30 years women, in asymptomatic women just coming for contraception clinic. They did a TVS, and they found there is 34% prevalence of adenomyosis, mostly asymptomatic, fortunately, but the mean age was 26 years. So that means it starts from such a young age. Now the diagnosis, the main part is diagnosis and classification. How to diagnose? We know the clinical, radiology, and histopathology. The clinical diagnosis, obviously the combination of abnormal uterine bleeding, I mean the heavy and infrequent menstrual bleeding, with or without and or dysmenorrhea. And I share with my students or my juniors that a typical combination of AUB and dysmenorrhea, we are almost always dealing with an adenomyosis, may or may not be an endometriosis, that is a separate issue, but mostly we were dealing with adenomyosis. Because with fibroids, this combination, heavy menstrual bleeding and dysmenorrhea, are really not so common. And we know that chronic pelvic pain, there can be dyspareunia, patient can first time attend with subfertility, there can be fatigue due to anemia, which I just told now about my own relative. She first presented with fainting out in a class while taking a class in the college with severe anemia, hemoglobin 5.6 gram per TL. So that's a history and the physical examination. The lost ritual. Just today, I got a patient in my hospital around late 40s, came with the hospital with an USG report for the first time, and she just put the USG report on the table, and doctor, this is my complaint. As I was attempting to ask that what is the problem she is having, she was regularly pointing to, doctor, I have the USG done, you look at the USG. Then I somehow convinced her to know the history, and then I asked that, do you think that this information is given in your USG report? She said no. Then when I asked that, can I take you to couch on an examination, she again told that, you have the USG done. So this is not her fault. This is actually our fault, because we doctors, particularly the doctors below the 40 years or 45 years now, we have all stopped doing the physical examination. And I know doctors, you are also, I am sure you have seen patients, have come to you with previous 4 or 5 consultations in different doctors, and none has bothered to do any physical examination. So, but yes, I, as a almost dinosaur age doctor, still believe there is some role in the physical examination. The bulky, soft, tender, mobile uterus, it goes rarely beyond 16 weeks of size. You can see, but that is rare. And the mobility restricted when associated with endometriosis. We can discover the asymptomatic, not asymptomatic, the endometriosis, there is no endometrioma, but there are uterosacral ligament thickenings, there is involvement of the pouch of Douglas, which is not picked up in the routine ultrasound or so. We can have the clue that there is an endometriosis also. We can be aware when we are cautious when we are planning for a surgical management. So the diagnostic pathway normally is you assess the symptoms, you listen to the symptoms, you do a physical examination if you have the time and the patient allows you. Then you do a TVS or TVS. Obviously, TVS is the preferred mode. You make a treatment plan. There are some situations when if you want that, yes, you think an MRI, particularly young girl, or when TVS is declined, TAS is inconclusive, then you do an MRI and then go to the treatment plan. And you make a diagnosis. If hysterectomy is indicated and agreed, do a hysterectomy, and you get the final diagnosis from the HPE of the uterus specimen. There's a final court of judgment. So 3 modalities we have apart from the clinical diagnosis. Now, before going to the classification, I just tell on the background because there are some ideal criteria for a classification. That first one, it should be reproducible and easily understandable. You make a very good research and you do a painstaking classification with sub classification 1A, 1B, 2, 1C, 4, and so on, so on. There is some difficulty in the reproducibility and understandability because most of us are clinicians. It's very difficult to keep in mind this so very, very complicated classifications. It should relate to the clinical severity. Just for example, endometriosis. Unfortunately, stage 1, stage 2, 3, and 4, these are not related to the clinical severity. Just so it should be related to the clinical severity. It should help in the treatment plan so that in ideal classification, yes, you have a class 1 this disease, this treatment plan is this for this one, stage 2, this treatment plan, stage 3, stage 3, 4, and that should predict the prognosis. Unfortunately, so though I have to spend some more 20 minutes or so, 15 minutes on the classification. Very few classifications can fulfill the criteria I have just described. The reproducibility, the predictability, the treatment plan, help in treatment, and so on. Now, let me start with the final court of diagnosis, that is histopathology. We all know the diagnosis by histopathology is a classical definition, presence of endometrial glands and stroma at a minimum depth of 2.5 mm below the endomyometrial junction with hypertrophic and hyperplastic myometrium. That's a textbook definition. And there have been classifications attempt to classify the adenomyosis by histopathological features. Starting from 1972, the Bard et al., then Nishida in 1991, then Levgard, then Samour and Varsilini et al. Depending on different criteria like depth of classification, depth of penetration, then continuity with basal endometrium, is superficiality, immediate or deep, and so on and so forth. Sorry for the interruption. Sorry. Hello. Hello.
We can hear you, sir.
Yeah.
Kindly continue, sir.
Sorry for the interruption. Actually, there was an urgent message. That's why. But unfortunately, the organ is already out. So this classification, yes, the pathologists may be very much happy. They have classified the adenomyosis and so on. With best regards to them, it's a painstaking classification. But the treatment, the thing is like that a house is unfortunately burnt, and then we call the fire brigade just to certify that the house is burnt to produce for make a document to the court and claiming and all these things. So to the clinicians, this classification carries a very little meaning that is adenomyosis is not a malignancy that we can classify and we plan the further management. Now, in advance to this classification, there was histopathological classification by Ramhusen in 2019. That depends on in contrast to the hysterectomy specimen, that was TCR specimen. That divided into intrinsic, serrated, and linear. They had got somewhat little bit relevance to the clinical severity, like intrinsic is most severe, linear is least severe, most response to linear and intrinsic variety. But again, the TCR is already done. It doesn't matter to the patient or the woman that whether it is linear, whether it is serrated, and whether it is intrinsic. What it matters to the clinician, the treating physician, and the patient, that whether the pain is controlled, whether the bleeding is controlled. But yes, it could make some prediction about treatment and prognosis, so better than the previous classifications that we can say. But unfortunately, TCRE is almost not done nowadays. So this relevance is again, I don't think how much relevant this is nowadays. Now come to the USG, the most practical mode of diagnosis and obviously the most practical mode of classification, most commonly used method. In 2018, Lazieri made an extensive classification. You can see the picture that it is stage 1, 2, 3, and 4, and so on. And there are so many minute descriptions like focal myometrial invasion, less than 4 millimeter to 6 millimeter, less than 20 millimeter, and so on. The beauty of this classification is someone actually follows it. There is very little chance of inter-observer variation. And it shows some clinical relevance. They divided into mainly, they predicted that diffuse disease is more associated with abnormal uterine bleeding, whereas focal disease is more associated with subfertility or again recurrent pregnancy loss. But the con is that you can see the picture, you understand that it is not very easy to follow in your clinic for each and every patient, even though we practice ultrasound sonography, gynecologists and non-gynecologists. Not quite easy. It is difficult to use in clinical setting and difficult to reproduce and interpret in each and every setting. It is a setting, is okay. Fine. Now, before this 2000 classification, there is a MUSA criteria. That is probably the most practical approach, the morphological uterus sonographic assessment. The basic MUSA criteria 2015, they did not make any scoring or so, they just described 9 features, which we are, I think, almost all of us are conversant with. That is interrupted junctional zone, irregular junctional zone, asymmetrical thickening of the myometrium, enlarged globular uterus, echogenic subendometrial lines and bars, myometrial cysts, hyperechogenic islands, transitional vascularity and colored Doppler, and fan-shaped shadowing. If we just see some pictures, they describe the features only. They did not attempt to classify the disease, and they did not put any certain number, like 3 of this criteria, 4 of this criteria, so on. I am coming back to this picture later on. Now, in 2019, Bosch et al., depending on the MUSA criteria, they again attempted to classify, to make somewhat classification like focal, less than 25% affection of the myometrium, diffuse more than 25% myometrial affection, adenomyoma, well-demarcated lesion. They tried to classify the myometrial their involvement, type 1, type 2, type 3, just like an endometrial cancer, up to half of the myometrium, beyond the half of the myometrium, so on and so forth, and largest diameter. But after that, probably the latest one and probably the most practical one is the modified MUSA criteria, revised MUSA criteria 2021. Now, this MUSA criteria modified on indirect features and direct features. The direct features told that number 1 is the myometrial cysts, hyperechogenic island, and some endometrial lines or bars. And the indirect features for rest of them, the asymmetrical myometrial thickening, globular uterus, transitional vascularity, and so on, fan-shaped shadowing, junctional zone interruption, irregular junctional zone. The beauty of this classification and diagnostic criteria is that even those who are not practicing the ultrasonography, even a good TVS is done, we can also again see from the ultrasound that, sorry, that is, yeah. You see the intermyometrial cysts, the hyperechogenic islands, the thickening of the disruption of the endomyometrial junctions, and so on. These are so clear in a good quality TVS. And we can make a definite diagnosis. Yes, there is an endometriosis, adenomyosis. So till now, this is probably the most useful and most easily reproducible criteria, the revised MUSA criteria, the direct and indirect features. And this is so obvious that there is very little point. And when I compare to the MRI, I will discuss that there is comparable between the MRI and TVS. Now come to the MRI for adenomyosis. Actually, MRI features are nothing but, I think, how much I understand these are just extrapolations from the very good TVS findings. Almost the same findings, just MRI interpretation obviously much more meticulous and more objective than the TVS because there is little interpersonal variation. Junctional zone thickening more than 12 millimeter, high intensity myometrial foci in T1 and T2 weighted images. And overall sensitivity is about 80%, and your specificity is more than 90%. So it is more specific. They can miss someone, but the MRI says that there is adenomyosis. So it is almost certain that we are really dealing with adenomyosis, obviously, along with corroboration with the clinical features and history and everything. Now, there are also attempts to classify the adenomyosis by MRI. Different attempts like Gotts, like Lindsay's, Kishi and Barzot et al. But there are again, depending on the hyperplasia, there is extent of invasion, there is different morphological appearance of the adenomatic foci, or again, levels of invasion and so on, internal, external, and distinct adenomyoma. But again, unfortunately, at the end of the day, the none has been clinically validated. They have MRI, the patient's symptoms. So most important again lies with the perception of the patient, the suffering of the patient, and treatment depends on that because treatment really doesn't depend, particularly for the medical treatment. It does not vary whether she has got any right-sided adenomyosis or left-sided adenoma or diffuse or left focal adenoma. Now, recent classification is Kobayashi 2022. They again tried to make it a little bit more comprehensible, though less complicated than the other. They took 5 criteria and divided these 5 criteria into sub-criteria. Affected area A is internal, B when there is external adenomyosis. Pattern, diffuse versus local. Size less than 1/3, less than 2/3, and more than 2/3 of uterine wall. They first time included the concomitant pathologies. Non-endometrioma, deep endometriosis, adenomyosis, and fibroid, and divided C 0 to 5. So one criteria is no criteria 0, one criteria 1, like and so on. And then localization, anterior, posterior, right, left, and fundal. Again, localization D1 to 5. What is the localization of the adenomyoma? If it's a focal adenomyoma, and expresses combination of a code like A1, A means internal, then second A means diffuse, then 1 means less than 1/3, and so on. Again, I don't think very much easy to for day-to-day practice of with the clinical gynecologist. So the take-home message is that on the final code, that clinical suspicion at the end of the day, examination still have their values, but I think again still now. And TVS is the first line investigation and sufficient in most of the patients because MRI has special situations, obviously indicated. We know I have already told that young girls, when the patient declines TVS, the TAS is inconclusive, particularly for the obese patients and very early adenomyosis. Then obviously MRI has a certain role, and when conservative management is indicated, like conservative surgery, adenomyomectomy is indicated, suppose in a subfertile patient or with recurrent pregnancy loss, we want to know the precise location of the adenomyosis, the involvement of the surrounding, like particularly the rectum and the pouch of Douglas. Yes, MRI has a definite indication, and particularly for the when you do a clinical study. Just for example, the conservative, suppose we are studying the effect of Mirena and adenomyosis. In that case, MRI has a very good objective value. We can reproduce with yes, MRI before treatment was this, and after treatment is this one. MRI has got a definite value. But for practical purposes, day-to-day practice, TVS and MRI has almost similar sensitivity and specificity. TVS sensitivity and TVS and MRI 70 to 80% specificity, both have 93%, above 90% specificity. But as I told, that MRI is much more objective, particularly for the research purpose. Obviously, histopathology is the gold standard, but again, I told that it's only a retrospective value. We move the uterus, you just confirm this is adenomyosis, that's all. And no classification system at the end of the day is yet universally utilized or accepted. So we rely mostly again on the diagnosis of adenomyosis and some particularly, yes, some criteria, the revised Musa criteria, I'm just going back to that. That is the most practical and most day-to-day used criteria, that is revised Musa criteria. And we make the treatment, we diagnose the treatment, and that's all. Thank you very much.
Thank you, Dr.
for
Partho.
madam for giving me the opportunity. I have to stop the sharing, I think. Yeah.
Hello, Dr. Partho, you have explained in a very beautiful and simple way, but every time we have to be endometriosis and adenomyosis minded.
Yes.
However, the classification, whatever may be the number of classifications available, but the most important still remains that be adenomyosis minded, clinical, then diagnose. In case of adult woman, TVS is the most effective, and in young girls, when we suspect it, we can do even MRI in young girls also. And all the classification are important from individual point of view, but nothing is universally accepted. So we have diagnosed. Now we go to the medical management. Okay.
Yes,
Our
Dr.
next speaker.
Now is waiting, ma'am.
Huh. Madam, Madam, will you speak or have a comment? Dr. Ramani, Madam. Our next speaker, should I?
Yeah,
Our,
yes. Good
our
evening.
next,
I'm very much here, Asha Rao. Enjoyed the lovely lecture by Dr. Partho.
our next speaker is Dr. Kalpana Mala Murugan, Madam. She
Yeah,
will speak on medical management of
yeah, I had
endometriosis.
requested for a
No.
changeover, Dr. Ramani.
Ma'am, I'm there, ma'am. Actually, now Asha Rao, ma'am, is going to speak on
Yes.
infertility management of
Okay.
adenomyosis, ma'am.
Yeah, I'm
Ma'am,
sorry
will
for
you?
changing the
No,
order.
ma'am. We
Okay.
have already said that. I think ma'am did not get it. Ma'am, shall you? Will you introduce Asha, ma'am, or can I?
Dr. Asha Rao is director of Rao Hospital and Care Hospital, Coimbatore. She is chairperson of Endometriosis Committee, FOXY, ICOG Governing Council member. She is past president of Coimbatore Obstetric and Gynae Society, year 2017 to 19 and 1993 to 94. Organizing chairperson of Endo Insight in 2021, International Endometriosis Congress with FOXY and SEUD, Yuva Foxy South Zone in 2019, organizing chairperson for the 8th National Ishar Conference in 2001. She has very many publications and research papers. Her special achievements are gold medal from the President of India from university in the final MBBS examination. So, madam, now the floor
Thank you.
is
Thank you
yours.
so much, Dr. Nirmala, for that warm welcome. And thank you so much, Dr. Ramani, for inviting me here. And I also thank the Endometrial Society, the team. It's a fantastic series of talks that are going on under the leadership of Dr. Ramani. And we are all happy to be a part of her team. And shall I just share the...
Yes, ma'am. Please share your screen, ma'am.
Yeah.
Pallavi, you've stopped sharing, right?
I am going to share Dr. Malaraj presentation.
No. You stop your screen so that ma'am can share her screen.
I already stopped. Yeah.
Yes, can you see that now? It's okay, right? Yeah. Can you hear me? Is the volume
Yes,
okay?
ma'am. Yes, ma'am. Everything is perfect, ma'am.
Yeah. So, greetings from Coimbatore. It's a nice hot summer that we're enjoying. And thanks to Dr. Ramani once again for giving me a talk which is very close to my heart. Adenomyosis, the challenges and outcomes in infertility. We have had a lovely lecture by Dr. Partho about the diagnostic aspects with so much clarity. And the disease, which was initially known to be a disease of Paris women, it was seen more often in women who are Paris and above 40 and fertile. Today, it is being seen more and more in infertile women. So, apart from severe dysmenorrhea and menorrhagia that it causes, it is a very important part of the etiology of infertility now. And also, it can cause impaired implantation and early pregnancy loss, recurrent pregnancy loss. So, whenever there is investigation for infertility or pregnancy loss, one has to definitely halt and proceed and look for the signs and symptoms of adenomyosis, because in 30% it can even be asymptomatic. And the true incidence is difficult to find out because we do not have a HPE confirmation in everybody. 21% of women with endometriosis concomitantly had adenomyosis, and 28% of subfertile population has adenomyosis alone, and 54% of young women with infertility, dysmenorrhea, and or menorrhagia could be having adenomyosis. So the trend is quite alarming, that it is seen more often, in quite a few of young women, almost 30%, and sometimes seen in 22% of infertile women less than 40 years undergoing ART. That means from a disease of Paris women, we are seeing it in younger women. This is perhaps because we have postponed our fertile years from 20s to early 40s, and also because of better diagnosis. Those days, apart from, historically it was diagnosed by histopathology at hysterectomy. But today we are diagnosing it very well with the ultrasound, which is available to all, which is an extension of our examining finger. Plus, of course, whenever we are in doubt, we can do MRI for further clarification, like Dr. Partho said. So the diagnosis is more because of better diagnosis and also because of postponing the fertile years. And there are any number of papers which have now shown that in cases of infertility, in case of ART, there can be lower rates of successful implantation and increased risk of pregnancy loss, translating into overall significant reduction in live birth rate. This is a beautiful paper by Yuns and Togas Tulandi in Fertility Sterility. And according to the original papers by Salim Daya et al., the clinical pregnancy rates were around 22% in women with adenomyosis in ART, whereas in non-adenomyotic women, it could be 47%. And the miscarriage rates also were much higher with adenomyosis, and 28% with no adenomyosis. And ongoing pregnancy rates also in ART with adenomyosis is 11%, whereas it is 45% in non-adenomyotic women. This is a paper from 2012. And any number of papers, Tamura et al., Shin et al., Yamaguchi, Razavi et al., have shown in their papers about increased risk of miscarriage, second trimester miscarriage, cervical incompetence, and you can also have PPROM, chances of PPH, hysterectomy. All this can happen because of adenomyosis. And all of us know about the pathogenesis. It's a benign invasion of endometrium into myometrium, producing diffuse enlargement of the uterus, which microscopically exhibits ectopic non-neoplastic endometrial glands and stroma surrounded by hypertrophic hyperplastic myometrium. This is very, very important finding. And it's a disease of the junctional zone. Here you can see the beautiful endometrium, the myometrium, and this thin area is the junctional zone, which is barely seen in normal women. And we already discussed about the diagnosis. And how does it cause problems? You can see here, there is a thickening of the junctional zone. There are problems in the endometrium, and there is also a myohyperplasia and enlargement of the uterus. At molecular level, the factors which are favorable to implantation, like beta-catenin, interleukin 6, macrophage, all these may be the factors which are not favorable to implantation are increased, as you see here. And the factors which are favorable to implantation, like HOX-A10 mRNA, HOXA11, integrin, interleukin 10, leukemia inhibiting factor. So the favorable factors may be decreased. So there are changes at the molecular level, and there is myohyperplasia, increased peristalsis, and this increased peristalsis or dysperistalsis is one of the important factors in infertility. Generally, at the time of ovulation, you see the peristalsis, uterine peristalsis, are from cervix to fundus and from fimbria towards the fundus again, favoring gamete transport, ovum transport, sperm transport, and fertilization. Whereas if there is hyperperistalsis, this gamete transport and fertilization may be impaired, and even implantation may be impaired. So this myohyperplasia also plays a very big role in infertility, and it is also the important reason for the severe pain and heavy bleeding of adenomyosis. And according to, there are any number of, this is a paper by Hashimoto et al., where he has shown that the chronic inflammation of adenomyosis can cause preterm delivery, second trimester miscarriage, placental malposition, preeclampsia, and there is also impaired uteroplacental perfusion leading to IUGR, PIH, etc. So you can have infertility and miscarriage, preterm labor, IUGR, and various obstetric problems because of adenomyosis. And it's also one of the important members of the etiology of AUB. So among the palm coin problem, you can see that A stands for adenomyosis. So whenever there is resistant menorrhagia and dysmenorrhea to treat, you should always think of adenomyosis. And diagnosis I'm not going into because already discussed beautifully by Dr. Partho. So these are the 7 signs of adenomyosis. And this is the big adenomyotic uteri that you diagnose with 2D, but you do not wait for this enlargement. You should diagnose it early with the 3D ultrasound. And you can see here the early infiltration of junctional zone by, there's a focal infiltration here, and this is again another slightly bigger focal infiltration. And this is a stage to diagnose. So all of you, my friends, you have to learn to do a 3D, diagnose it early so that you can prevent the complications or treat it with medication right in the beginning. And how do we manage? Management depends on woman's age, clinical symptoms, focal or diffuse, and the reproductive status. And it's a lifelong management. And for management, we have medical, surgical, and also ART alone or in combination. Talking about medical management, we had the wonderful medication that was danazol. I remember in 1993, we gave it to a woman with severe pain and bilateral corneal block as seen by laparoscopy those days in 1993. And when we stopped the danazol after 4 to 5 months, there was a spontaneous conception and a term delivery. But this wonderful drug we could not use further because of the androgenic problems. And we have Dr. Kalpana who will be talking to us more in detail about medical management. But we have today GnRH analogs, Dinoges, aromatase inhibitors, intrauterine system with progestogen. Even in infertile patients, you can use it, ART. And you also have non-surgical interventions like uterine artery embolization, HIFU. And of course, surgical treatment was being practiced right from 1952. And very many modifications have happened in the surgical management. And just to discuss briefly, OCP are not so popularly used, I would say, but you can use it in young girls for relief of pain. And Dinoges was popular in the last decade, but today I think we have very many drugs available like GnRH agonists and antagonists. Again, since Kalpana is going to talk about it, I'm going to skip this. So when a woman comes to you with infertility and if you have severe pain, do the ultrasound and look for endometriosis, adenomyosis, other factors, and treat her like anybody else. You must do the tubal study, and you must also do the semen analysis, ovulation study. And if it is a mild adenomyosis, you can give them a chance to conceive just by maybe looking at the fertile period. And sometimes if the tubes are patent, you can also do IUI. And whenever the endometrium is thick, you can use for these people LNG-IUS. We were very much worried earlier about LNG-IUS in infertility patients. Today we know that women with adenomyosis and thick endometrium, they respond very well to LNG-IUS. Continuous exposure leads to thinning of the endometrium and relief of pain. And when you remove the Mirena after, you can keep it for 4 to 6 months, and you can study every 8 weeks about the endometrium, endometrial thickness regressing. And when you remove the Mirena, many patients of mild adenomyosis may conceive. So initially you treat them like anybody else with the maybe perhaps trying fertile period or IUI. And if there is difficulty in conceiving, then maybe we go in for ART. And so far, not many data are available about the efficacy of different treatments. Which is best for adenomyosis? We do not have proper data. So if somebody asks me, when do you use medical management? When do you use surgical management? I think all the indications are overlapping. One has to take their own criteria depending on the age of the woman, desire for fertility, and type of adenomyosis. This mild adenomyosis, I said you treat them almost like unexplained infertility. If it is slightly bigger adenomyosis, you can do a medical suppression because decreased pregnancy rate, 23% versus 44% in non-adenomyotic women was seen. And ultra-long downregulation improved the pregnancy rate. So whenever there is a moderate adenomyosis, you can give GnRH suppression for 3 to 4 months and then again allow them for even a natural conception. And if there is a failure, you can take them up for ART. Pre-IVF GnRH for 3 to 6 cycles optimizes ART outcomes. And these GnRH analogs can almost give you a 50 to 60% reduction in uterine volume. New et al. Found that a long course of downregulation can improve the implantation rate, clinical pregnancy rate, and ongoing pregnancy rate in patients with adenomyosis. And after 2 to 6 months of GnRH analog, the mean uterine volume was significantly reduced from 180 cc to 86 cc, as seen in the papers by Zhu et al. And same observation we have also had at Rao Hospital. And I call it a medical adenomyomectomy. If a uterine volume can come down from 180 to 80 cc, what more do you need? You need not do a surgery at all. So always try medical management for volume reduction and also reduction of the adenomyotic lesion. And progesterone add back is required for these patients. Whenever I use it for more than 2 months, I definitely give a progesterone add back. And again, about adenomyosis suppression, there have been no adverse effects on IVF outcome in women treated for adenomyosis with GnRH suppression prior to ART. So if you give a GnRH for 3 to 6 months prior to embryo transfer, reduce the volume, the success rate in adenomyotic and non-adenomyotic women were almost equal. You can see here, with the GnRH suppression, the pregnancy rates went up from 24 to 51%, and implantation rate improved from 16 to 32%, and also the ongoing pregnancy rate went up from 21 to 48% in women with adenomyosis with prior GnRH suppression. And earlier we used to do a GnRH suppression, then do the egg collection and then a transfer. But today we have dissociated egg collection from transfer. We do the antagonist protocol for ovarian stimulation and then do the embryo freezing. And later you do the frozen thawed embryo transfer after reducing the uterine volume. And this seems to be extremely successful. Reduction of uterine volume can be done by either surgery or medication. But when you have wonderful drug for medical suppression or medical adenomyomectomy, we hardly do any adenomyomectomies unless the uterus is big. This is one of our patients with the previous IVF failure elsewhere. She also had a surgery earlier for endometriosis. You can see here, this is the posterior adenomyosis. It looks almost like a myoma, no, impinging on the endometrium. Many times my colleagues would say, let us do an adenomyomectomy or let us do a hysteroscopic evacuation of this, excision of this mass. But this lady, we did the egg collection, embryo freezing, and suppressed her for 4 months, 16 weeks with GnRH analog. And when we did the embryo transfer, she conceived, and the child is 4 years today. So we have to have our own decisions about which patient deserves medical management and who requires surgical management. Once again, a paper by Conjuro et al. Showed that adenomyosis may not affect implantation, but it can cause miscarriage. Again, when you suppress the adenomyosis, the chance of miscarriage were much less. And what should be the ideal uterine volume? Still, we have no answers, but roughly it seems to be something like 98 to 120 cc. The normal uterine volume is around 60 to 70 cc. And whenever it is more than 100 cc, chances of miscarriage were higher and live births were less. But when you bring down this uterine volume to less than 98 cc, definitely this can be reversed. The chance of pregnancy are higher and live births are more, less abortions if you can bring down the uterine volume to less than 98 cc. So number of miscarriages are also less. What's the role of Dynogest in these patients? It is very good for the pain relief, but not very good for bringing down the uterine volume. And this is a paper by Matsushima et al., where they showed in their 16-week study that when they gave GnRH analog, the volume came down from 307 to 177 cc. Very good volume reduction, almost 50%. Whereas low-dose estrogen progesterone in Dynogest, the volume reduction was not at all significant, from 226 to 230 and from 232 to 262. So nothing happens with Dynogest over 16 weeks. You may see a volume reduction over 6 to 8 months. So whenever it is infertile patients, it's a GnRH, and today it's a GnRH antagonists, which are very useful in volume reduction. Aromatase inhibitors we have used in patients with resistant adenomyosis earlier, before the days of antagonist. So when you combine GnRH analog with antagonist, the volume reduction was almost 60%. And the pregnancy rates went up, and live birth rates were also very good. And there are very many new medications like sperms. But the best medication today is the antagonist, because the antagonists are rapidly acting. There is no flare effect. They bring down the uterine volume rapidly. And you have two types of antagonists available in India today. One is elagolix and one is relugolix. Elagolix you can use 150 milligram per day or 150 milligram twice a day or 200 milligram twice a day, depending on the severity of the condition. And it of course causes hypoestrogenism and can cause BMD reduction when used for more than 6 months. So today we have the Relugolix, which is Relu is with combination of progesterone and estrogen, and you can use it for long term. But as far as the results are concerned, I'm very happy with the results of Elagolix, because the volume reduction is almost 50% within about 3 months. So patient who is waiting for embryo transfer, I think Elagolix molecule works very well compared to Relugolix. Relugolix will be okay for the endometriosis and for a long-term management. So who will benefit from uterine surgery in adenomyosis? Well-defined adenomyoma, which is large, more than 5 centimeter, recurrent miscarriage or recurrent implantation failure, not responding to medication, in spite of repeated IVF and these are the only conditions that you go for surgery, not for everybody, because there are chance of rupture uterus. You can see this beautiful paper by Tan et al. Showed that the chance of rupture uterus could be almost 6.8% women after adenomyomectomy. And there can be higher chances of adhesion formation. Sometimes even a tubal block can happen. Chance of placenta accreta also could be higher after adenomyomectomy. So as far as possible, we try to avoid an adenomyomectomy, but you have wonderful methods like the triple flap method. And today even you have the 4 flap method. So there are so many newer methods have come up. This is actually the open method by Osada et al., where it says 54% pregnancy rate and no rupture. The same thing is now being practiced by laparoscopy also. So, but traditionally, according to Osada, for focal adenomyosis, laparoscopy is good. If it is diffuse adenomyosis, you can do a laparotomy. But because of the increase in technology, equipment, experience among our scientists, I think today we are able to do many more laparoscopic adenomyomectomies. But you have to wait for 5 to 6 months for the healing and leave a good flap of almost 1 centimeter so that the chance of rupture uterus will be less. And after 30 weeks, you keep these patients close to your hospital so that if there's any pain, which you think as preterm labor, may be possibility of rupture uterus. So always keep them under observation after 30 weeks, close to the hospital. This is one of our patients, 39 years, infertility of 15 years, adenomyomectomy at local hospital, and she had recurrence within 1 year, no pregnancy. So she came to us with no ovarian reserve and married for 15 years, and again a large adenomyosis of 6 to 7 centimeter. There was no way we could repeat a surgery because she already has undergone adenomyomectomy. So this was 15 years back. We gave her 2 doses of long GnRH agonist. The uterine volume came down, and then she had the embryo transfer, and she's a happy mother of twins who are 15 years today. This is one of our recent patients. She came to us at 28 years unmarried with severe pain and severe dysmenorrhea and menorrhagia, and a uterine volume of 196, focal adenomyosis with PCO, and she had small chocolate cysts in the ovaries. She gives a history of almost from the age of 10 years, how she got early menarche, early menorrhagia, then she started dysmenorrhea, then she was given OCP in the local area. And by the time she came, she had taken a lot of medication. She had even taken Dynogest and she had no relief. So initially, this is the long chart. No? She was with us from 2020 to 26. And in 26, she has had a live birth. So she had already exhausted the OCP and Dynogest treatment. So we gave her Lupride and she was happy for some time. And naturally, when she stopped Lupride, the uterine volume went up again. So we gave her a Mirena. Though she was unmarried, she accepted the Mirena, but the Mirena got expelled because of the adenomyosis. And 2023, she got married. And she said, no, let me try naturally for 1 year. She did not conceive. So the uterine volume was around 117 at this stage. And later, the uterine volume started going up again because she was not being suppressed. Then we did her egg collection. And after egg collection, with all that estrogens that are pouring out of ovaries, her uterine volume almost went up to 274 cc. So measuring the uterine volume is very important, which not many centers are doing. So kindly learn to measure the uterine volume. So at marriage, her uterine volume was 117. Now after egg collection, it became 274 cc in 2024. So we tried suppressing her with Lupride again, but there was not enough response. So in Jan 2025, we did a laparoscopic adenomyomectomy and left chocolate cystectomy. And then we gave her Egolix for about 8 weeks, 8 to 12 weeks, I think. And then the uterine volume came down beautifully to 140 cc, 148 cc, and then 73 cc. And with the, you can see this before surgery, her uterine volume was 257 cc. And post-surgery, the uterine volume came down to 148 cc. Then with Egolix, it came down to 70 to 90 cc. And after embryo transfer, she conceived and she has had a live birth now. She delivered at the 31 weeks she has delivered. And baby was in NICU and she's doing well. So that was a very happy ending for an unmarried girl who came to us and she was with us for 5 years. And with adenomyomectomy and Elagolix suppression, she did very well and we had a live birth. So to conclude, when women come to you with adenomyosis-associated infertility, do a routine infertility checkup, including measurement of ovarian function and semen analysis. Treat them like anybody else, allow a timed intercourse or IUI. And if you do not conceive, you can suppress adenomyosis and allow them to conceive again naturally if the tubes are patent. If they do not conceive, you kindly take them for IVF rather than adenomyomectomy because many of them will conceive with egg collection, suppression of uterine volume, and then embryo transfer. Many of them will conceive. If they do not conceive in spite of 2-3 embryo transfers or if they have severe menorrhagia or pain, not responding to medical management, that's the only time you take them up for surgery. So pre-treatment with GnRH or GnRH analog or antagonist appears to be beneficial in improving pregnancy rates in women with adenomyosis. The benefits of fertility surgery vary greatly, to be performed only in selected patients who have severe pain symptoms or failed medical management with IVF. So let us be good to these suffering women and give them the best for all their years that are being spent around our clinics. Thank you all, and thank you, Dr. Amani Devi.
Thank you, Madam. Asha Rao, for your wonderful experience sharing in a very simplified way with all of us. Really, experience matters a lot, and every day we learn something, and newer drugs are coming, and we see that the necessity of doing surgery will decrease day by day. And the unmarried girl visiting to you and now having a delivery and a live baby in her hand is a very big achievement at the time of proper diagnosis and management. Madam Ravani Devi, please comment.
As usual, Asha Madam means adenomyosis and infertility, and she had shared her experience and so many newer aspects, how to promote the pregnancy. She has given a practical tips. Thank you, Asha Madam. In spite of all your busy schedule, you have joined me. And then
Thank you, Ravani, for allowing me to change my time. Sorry for disturbing.
no, madam, you have to
Thank you.
thank. Okay, welcome, Dr. Sanjeev Good sir. Also, I think I could see Dr. Sampath Kumari somewhere. Pradeep sir also had put in a message. Sampath, are you there? I think probably she
Yes.
wanted to say hello to everyone. And all of you know that she's contesting for the post of President Foxy in this year. So I wish her all the best, and I request all the members to support her to have a president from the South after a very long time. Thank you, members. Harshini, I think you can go to the next speaker.
Pallavi, can you share Mala ma'am's?
Yes, I'm sharing.
Hello. So our next speaker is Dr. Mala Raz. She will speak on surgical management of endometriosis.
Adenomyosis.
So, good evening, everybody. At the outset, I would like to thank TNFOG and Dr. Ramani Devi Madam for this opportunity to present my case on adenomyomectomy. So, as we all know, adenomyosis is defined by the presence of So the defect generally created after adenomyectomy can be quite large generally when we do a laparoscopic or an open surgery. But finding ways to maintain this uterine wall thickness is the one of the most challenging thing in case of a laparoscopic adenomyomectomy. So if you see most of the women with adenomyosis in the earlier days, they had a hysterectomy or a functional hysterectomy. So because the reconstruction of the uterine wall was a big challenge. Now with various techniques available, we are able to reconstruct the uterus and allow the women to also go through a pregnancy. And also it has been found that now the women coming with adenomyosis are at a much younger age, and this is mainly because of the early detection of adenomyosis with the advent of the 3D ultrasounds and the MRI features. And also it has been found that most of the women, they are starting their pregnancy treatment little late. As a result, we have an young crowd which is coming with adenomyosis, and obviously we need to make sure that we save the uterus and allow them to have a baby. So looking at the origin of adenomyosis, there are various theories in the mechanism of adenomyosis. The commonest one is the Samson theory, wherein the retrograde menstruation is the commonest phenomenon, where the endometrial and the stromal cells are deposited into the myometrium. And next will the TR mechanism, which is tissue injury and repair mechanism mechanism wherein the injury to the endomyometrial junction, this triggers the metaplasia of the displaced embryonic pluripotent remnant cells, and this results in the hyperplasia of the myometrium. And the third would be the invagination, where the endometrial basalis is structurally drawn downwards into the myometrial layers. And the fourth would be the active invasion, where the heterotropic endometrial glands and the stroma actively embedded and proliferate within the myometrial walls. So now there is a shift in the demographic demands based on the new surgical priorities. Earlier, as I mentioned, the patient profile was such that they came mainly for symptom control, that is for just the pain relief and also for the bleeding issues. But now in the current scenario, the modern clinical priority of the women is that they want a pregnancy. They delayed pregnancies and advanced imaging, all this are helping us, and all these are causing an increase in the incidence of adenomyosis, and we need to offer them a conservative laparoscopic surgery where the preservation of the function is very vital. The advances in the transvaginal ultrasound and the MRI combined with delayed pregnancies demand conservative laparoscopic surgery to preserve the function. So if you look into the pathogenesis, it is important to understand the pathogenesis so that we will be able to understand the disease process much better and offer them the right modality of treatment. First, there will be abnormal angiogenesis, which occurs mainly because of the overexpression of VEGF and also the reduced anti-angiogenic markers, which severely repair the endometrial, that is embryo receptivity. So and next would be the dysfunctional hyperactivity, where the pathological calcium transportation within the myometrial cells, they cause irregular high and hyperactive muscular contractions. And then next would be the arrhythmic peristalsis, where the abnormal contractility structurally disrupts and prevents the normal sperm transport mechanism. And the fourth would be the disorganized tissue, where the molecular alteration triggers the intensity and thereby decreasing vital adhesions and thereby preventing the implantation. So all these are the mechanism by which adenomyosis causes implantation failure and hampers the fertility of women. So to diagnose adenomyosis, various modalities are available. The gold standard is an ultrasound, wherein you are able to pick up the adenomyotic lesions very well based on the direct signs and the indirect signs. The direct signs indicate the displaced endomyometrial component, whereas the indirect signs indicate the muscular component. The various direct signs are the anechoic lacunae and the cyst, the subendometrial lines and the buds, the hyperechoic lines, and the interrupted endomyometrial junction. Whereas if you see the muscular components are, you have a indistinct endomyometrial junctions, enlarged globular uterus with asymmetrical thickening. There is a fan-shaped shading and also thickened irregular junctional zone. So these are the hallmarks of the ultrasound of adenomyosis, apart from increased vascularities which in the Doppler. Now this 3D ultrasound also adds to the accuracy of adenomyosis, and we can see the interrupted endomyometrial borders, indistinct endomyometrial border, and also endometrial lines and buds. But the most important thing is we also need to measure the thickness of the junctional zone and at various levels, and the difference between the two thickness would clearly indicate the presence of adenomyosis, which should be than 4 mm. So here generally the normal thickness of the junctional zone in adenomyosis is increased to more than 12 millimeters, and even in MRI also we can see that the difference between the maximum and the minimum junctional zone difference should be more than 4 mm, which indicates the presence of the right technique of adenomyomectomy. So there are various techniques of adenomyomectomy performed. You have the type 1 adenomyomectomy and the type 2 adenomyomectomy. The type 1 is mainly for focal adenomyosis, whereas if you see the type 2 is for the diffuse or the global adenomyosis. In type 1 adenomyosis, this is designed to completely remove the localized adenomyotic tissues. So as a result, we can follow certain technique like T-shape adenomyomectomy, or you can follow the Y-shape adenomyomectomy, H-shape adenomyomectomy, or you can also do a four-petal technique. Whereas in case of type 2 adenomyomectomy, where you have a global adenomyosis, the most important thing is here we have to remove as much as adenomyotic tissue and at the same time preserve the myometrial reserve. In such cases, we have to maintain a proper balance, for which the proper exposure is very vital. In case of diffuse adenomyosis, it is not possible to remove the entire adenomyotic tissues, but we need to have a strong judgment as to how much we need to remove, so that we do not compromise on the integrity of the scar at the time of her pregnancy. So this maintaining the exact balance between incomplete pathological removal and excessive excision of the healthy myometrial tissue is the most vital factor which one needs to keep in mind in case of adenomyomectomy. Just like how in endometrioma one needs to maintain the ovarian reserve, in case of adenomyosis one needs to make sure they maintain the myometrial reserve. So this is the key behind the adenomyomectomy success. So what are the challenges that one can encounter during adenomyomectomy? The most important thing is first the plane. The planes are obscured. Just as in myomectomy, here we will not have a good plane, because in myoma surgeries we will have a very beautiful pseudocapsule, and that will help us to identify the plane and enucleate the myoma. Whereas in case of adenomyoma, because the plane is not present, we will not be able to get into the exact demarcation between the abnormal tissue and the normal tissue. So this plane being obscured is the most challenging step in adenomyomectomy surgery, where one needs to maintain the myometrial reserve by leaving adequate amount of the serosa, and also ensuring that it will stay away from the endometrial cavity by maintaining sufficient distance from that of the endometrium. So the dictum is you need to maintain 1 centimeter from the thickness from the serosa and 1 centimeter thickness from the endometrium. So this helps us to reconstruct the uterus and also make sure that we do not enter into the cavity of the uterus. So if this is maintained, then obviously we will be able to excise adequate amount of adenomyotic tissue, and also we will be able to close the wound adequately. So the biggest challenge in case of adenomyomectomy is the closure of the wound, for which most of the time people end up doing a hysterectomy. So for proper closure, we need to plan the incision in such a manner that we get adequate amount of serosa to approximate the edges. Here one needs to understand that in myomectomy we have a healthy myometrium to approximate, whereas in adenomyosis we do not have a healthy myometrium, and while doing an adenomyomectomy all the diseased adenomyotic tissues are excised. So as a result, the uterus is devoid of a healthy myometrium. So we need to only approximate the serosa to serosa and obscure the and occlude the dead space. This dead space occlusion is very important because this only helps us to give good strength to that of the myometrium. So that is why various techniques have been designed so that we are able to achieve this closure, and also we are able to occlude the dead space so that we are able to maintain the integrity of the wound. So the crucial principle is that the tissues must be preserved for adequate repair to avoid a functional hysterectomy beyond maximized cytoreduction. This is what needs to keep in mind. So the four pillars for surgical success are, so one is the wall thickness. As I mentioned, you should have at least 1 centimeter serosa maintained, and proper layer alignment should be done, and also endometrial integrity should be maintained, and resection should be balanced, where you remove only the damaged myometrium and retain the healthy myometrium, and also make sure that you do not enter into the endometrial cavity. So there are various techniques which have evolved over a period of time to achieve this principle. The one is the T incision technique, which includes U-shaped suturing also. This was designed by Sanetta. Then you have the H incision, which was an early approach to managing diffuse boundaries, and you have the two flap technique, which was pioneered by Takuchi et al. And then you have the triple flap, which was advanced closure by Osada et al. So now in the triple flap is the one which was commonly performed all this while, but the challenge here, problem with the triple flap is that here it is not tissue approximation. Here the serosa is approximated to the myometrium. So as a result, the proper principle of tissue approximation will not be achieved here. So to overcome all these issues, the four petal technique has come in, wherein the cruciate incision is made onto the uterus, and the adenomyotic tissues are removed by just opening up this petal and making sure that you are removing all the pathological tissue, and at the same time maintaining the healthy myometrium. So this four petal technique is found to be quite promising. So now let us look at the surgical aspects of the adenomyomectomy. So here this is going to adenomyomectomy. So wherein you can see that I have made a T-shaped incision by making a first horizontal incision and then making a vertical incision. So this should be done in the most prominent portion of the adenomyoma. So while doing this T-shaped incision, so the adenomyotic tissues get exposed and we are able to excise the adenomyotic tissues. So here you can see that this the vertical limb of the incision, the adenomyotic tissues are present, and we are gently excising these adenomyotic tissues, maintaining the serosa of the uterus. So here you can also differentiate by the look and the consistency of the tissues between the healthy myometrium and that of the adenomyotic tissues. So here you can see that the white half tissues are the adenomyotic tissues which have been excised. There is a small inadvertent opening of the endometrium. So I am just selecting the endometrium. So we need to make sure that now this helps us also to identify the exactly the endometrium. So just 1 centimeter above that, we have the excise of the endometrium tissues. Then whether to close the endometrium or not is even the next question. So the endometrium does not need to be closed. So you can just close only the myometrium, overlying the endometrium, thereby obliterating the dead space, and as as a result, we can maintain the integrity of the myometrium and the uterus as well. So this vertical incision, first we suture the vertical limb always when you have vertical incision, because it is a lot more easier when you do the vertical suturing first and then come to the horizontal suturing. The bar sutures, of course, this helped us to ease out the suturing techniques very well, and as a result it has made a job lot more simpler without throwing any knots. And approximation also is very good, and because of the presence of barbs there is also uniform tension on the suture end rather than having the irregular tension. So this helps us to give a proper wound healing, and the integrity of the scar is maintained, and finally it is removed in a bag. So this is so this is exactly the similar one, and now this is the triple flap technique by Osada. So here in the Osada's triple flap technique, Osada did a open surgery. So first he did laparoscopy to identify the adenomyotic tissues and plan the surgery, and then finally it was opened, and then here the serosa would be approximated to the myometrium. So here you can see that there is a hemostasis is being maintained by using vascular clamps or on the utero-ovarian ligament. This is an open procedure which Professor Osada is doing, and here you are just tying a tourniquet. He is tying a tourniquet around the uterus so that the blood supply to the uterines are temporarily cut off, and so this is called the clamp tourniquet on the uterus. Then again a vertical incision is being made on the uterus. So if you want, we can also inject vasopressin, but the French do not use vasopressin, but we do use vasopressins, and it helps us to maintain hemostasis. So now the adenomyotic areas are all identified and they are all being excised. So here you can see the demarcation between the healthy myometrium and also the adenomyotic tissues. So all the adenomyotic tissues are being removed, and some amount, as I mentioned, 1 centimeter of the serosa is being retained, and then the adenomyotic tissues are now being excised. So once this adenomyotic tissues are excised, now the integrity also is checked with the methylene blue, and then finally the flap is now created. So while creating the flap here, this is how it is. This is why it is called the triple flap technique, where the serosa and the myometrium are approximated after taking the initial approximation of the dead space. So here you can see the flap now is getting formed after the this is a serosa closure, and then you can see the flap being the flap which was raised is now being closed. So you can see that the this serosal layer only would be going on to the myometrial layer. So as a result, the tissue approximation is not achieved. So here you can see that little raw area is created on the serosa for better wound healing. So this is the Osada triple flap technique. And finally the vascular clamps are all released, and the blood flow also starts resuming. So this can also be done laparoscopically by using a uterine artery ligation at origin temporary method. So the anatomical alignment versus the structural overlap is the the difference between the Osada triple flap and the four petal, the current technique. So where in the traditional flap method, the layers are artificially overlapped, and also they create the structural inconsistency and uneven healing planes, and these are prone to weakness under in the future pregnancies. Whereas the modern four petal technique, the layers are anatomically aligned, and this reconstructs the natural symmetrical integrity of the myometrium, and also support, it is able to support the pregnancy very well. So this is the latest four petal technique, introductions of the four petal technique in the current scenario. So this is the difference. As I said here, the dead space has to be obliterated because we do not have a healthy myometrium. So we need to take a stitch on the serosa and on the bed of the adenomyoma, and then back to the serosa. And this is a concept of repair. How you can see how adenomyoma surgery is different from that of the myometrium. So here of myomectomy. So you can see you have a healthy myometrium. So you have myometrium at an approximation. Whereas in adenomyoma surgery, there is no healthy myometrium. As it says, you have a serosa to the bed of the base of the adenomyosis. Okay, we have to approximate. So achieving complete visualization and targeted instruction are the key points of four petal technique, where we are able to have a 360-degree visualization, which provides an excellent and unobstructed line of sight to all the boundaries and the sides of the underlying lesions. So we are able to precisely excise as much as adenomyotic tissues and retain the healthy myometrium. And also the targeted dissection goal is that it eliminates the disorientation caused by the older techniques by providing a clear and targeted anatomical map for removal. And also the outcomes are very good, with a good post-operative symptom resolution while actively preserving the uterine wall thickness. So this is the four-petal technique. So this is how we perform the four-petal technique. So identify where exactly is the adenomyotic lesion, and then inject vasopressin for hemostasis, and then take a cruciate. So next you can see this four petal adenomyomectomy has really revolutionized the adenomyomectomy technique.
Ma'am, just a minute. There are two more slides. Let me share the screen once again. There is some technical glitches. Just a minute.
Myomectomy, the chances of rupture here are more, especially the mid-trimester rupture. So these are the success formula which have been highlighted earlier for adenomyomectomy. So thank you so much for the patient listening and giving me this wonderful opportunity. I would like to thank the entire team, TNFOG, and Dr. Ramani Devi Madam for this wonderful opportunity.
Thank you, Dr. Mala, for your wonderful presentation on adenomyomectomy and the various procedures to form the flap, and so as to reduce the chances of future rupture of the uterus if the patient goes for the pregnancy. So now we come to the next topic. Dr. Kalpana Mala Murugan will be speaking on medical management of endometriosis. So, madam.
Pallavi share Kalpana ma'am's CV.
Yeah, she is Foxy Infertility Committee chairperson, founder secretary, Madurai chapter of TAPISAR, co-chairperson Infertility Committee of Tamil Nadu FOG, past vice president of MOGS, organizing secretary MOGS Silver Jubilee Conference in 2018, MOGS Annual Conference in 2022 and 23, South Zone VP Conference in 2023, and Mid-Year Conference in 2026. She is member of Institutional Ethics and Principal Investigator in many clinical research trials. She is course director of postdoctoral fellowship in endogynecology and affiliated to MGR Medical University. So, madam, we all welcome you to this wonderful session, and the floor is yours.
Thank you so much, Nirmala Madam, for your kind introduction. My sincere thanks to Ramani Devi Ma'am, who is a scientific chairperson of this CME webinar in association with the Endometriosis Society of India. My regards to President of Endometriosis Society of India, Das Mahapatra sir, and also Secretary General of Endometrial Society of India, Dr. Pradeep Kumar Mitra. So endometriosis, even now it is an enigma because the symptoms do not correlate with the severity of the disease, and many a times the symptoms are not related to the classical triad of symptoms like dysmenorrhea, dyspareunia, or chronic pelvic pain. Many a times it is vague symptoms, even diagnosis is difficult and delayed for almost 6 to 7 years. So when we think about the prevalence of endometriosis, 1 in 10 women are affected by endometriosis, and Indian population have almost 26 million women suffering from endometriosis, and it starts from adolescent girls. Almost 70 to 80% of adolescent girls with chronic pelvic pain have endometriosis, and when we come into the reproductive age group, 50% of infertile couples have endometriosis. And when we have endometriosis, even in the adolescent group, it is going to be a severe endometriosis. So the delay is almost 7 years. And when we look into so before jumping into the treatment modality, we need to consider the symptoms and age group in which the patients come to us, and what is the need for the patient. According to their need, the treatment modality has to be planned, and for that we need to know about the pathogenesis of endometriosis. Various theories have been put forward, starting from Samson theory, retrograde menstruation, then even in pre-pubertal girls, endometriosis became common. Then coelomic metaplasia came into the picture, embryonic remnants, and out of these are the initiating factors, and propagating factors are obviously estradiol dominant milieu, and also immune dysfunction, altered T cell and B cell function had also been suggested, and apoptosis suppression genes had been documented in these patients with endometriosis. Ultimately, oxidative stress and lymphatic and vascular dissemination has also been documented in these patients, explaining extrapelvic endometriosis and genetic factor, and which is almost first degree relatives have 7 times increased risk of endometriosis, and MDA patient, Mullerian duct obstruction patients have increased incidence of endometriosis. Ultimately, the patient ends up with either superficial or deep seated endometriosis. So, the hormonal modification like hyperestrogenism and progesterone resistance is the basic factor here in endometriosis. Increased aromatase and ERB receptors are increased, and progesterone receptors are reduced in these patients, and COX-2 increased, which ultimately results in increased prostaglandin E2, and various inflammatory markers like interleukin 1, 6, 8 increased in these patients, and it is macrophage predominant situation, and it is considered as an inflammatory disease, and also altered NK cell activity. So immune modulation comes into the picture for endometriosis therapy. And also angiogenesis is increased in these patients, documenting increased VEGF in these patients. So ultimately tissue repair and fibrosis where nerves are trapped, and ultimately these patients have increased pelvic pain. So knowing about all these pathologies, medical treatment involves each and every pathology, and so ultimately we have many drugs available in the market. So we have triad of symptoms. So we need to understand the goal of our therapy. If a patient is coming to us with menstrual cramps, pelvic pain, dyspareunia, or painful urination, the treatment should be based on her symptoms and mainly medical management. If the patient is coming to us with infertility, medical management has got minimal role, and surgical or IVF will be the treatment of choice in these patients depending upon her stage of the disease. So this is ASRM conclusion. Medical treatment is the first choice in adolescent endometriosis, and also in patients with severe chronic pain, and also in post-operative cases where recurrence is the main symptom. And in these patients, medical management is the first choice of treatment. The problem with the medical treatment is even after surgery, it's a recurring disease, and almost 50% of patients have recurrence in 5 years. So in adolescent girls, the primary treatment should be medical treatment, because early intervention and recurrence will obviously reduce her ovarian risk. So ASRM also concluded that medical management is the first line of treatment in adolescent girls, and if a patient had undergone surgery and coming to us with recurrence, or sometimes in the post-operative period to reduce or postpone recurrence, medical treatment is needed, especially if she is not bothered about her fertility. Or sometimes if the disease is severe and deeply infiltrating endometriosis, sandwich therapy can also be tried when surgery is not possible, refused, or to reduce the burden. Medical treatment is useful. So even if the patient is not responding to painkillers, when we suspect endometriosis, even without surgical confirmation, Yeshre concluded that empirical medical treatment is acceptable in adolescent girls before going into surgical procedure. We can try with any of these drugs, starting from progesterone, COC, GnRH agonist after 18 years, antagonist, aromatase inhibitors as a third line management. We have many recent drugs available in the market. Also, extrapelvic endometriosis, sometimes in the lungs or sometimes in brain, extrapelvic endometriosis. If it is not manageable with surgery, then medical treatment should be considered. So this is let us look into the literature evidence of recent ESHRE 2022 also. We have various choices starting from COC, which is available as oral preparation, vaginal ring, or even transdermal. Continuous use should be considered to reduce the disease burden. And also the next thing is progesterone, which is also considered as the first line of management. We have multiple progesterone preparation, LNG, ETG, implants, and we need to know about the side effects associated with each drug. The second line of treatment is GnRH agonist. The main problem with GnRH agonist is its impact on bone mineral density. GnRH antagonist is also available nowadays, but the evidence is limited. So it also has got an impact on bone mineral density. And third line of treatment is aromatase inhibitors, where the patient is refractory to any other medical or surgical treatment. It should be combined with any of the above drug can be tried. So starting from NSAID, we have various drugs which had been documented and studied and established its efficacy. The problem with the COC, which was introduced initially, the problem is various studies had documented the minimum estrogen in COC may stimulate the disease progression. Continuous COC can cause breakthrough bleeding, which is not comfortable or patient friendly. Sometimes it is not effective in patients with dyspareunia or chronic pelvic pain. And COC is not approved in some of the countries. NuvaRing is also available, which is patient-friendly with 15 micrograms of ethinyl estradiol and 120 microgram of ATG. Which can also be used. We have various progesterone preparations starting from first generation medroxyprogesterone acetate, second generation LNG, third generation desogestrel, and fourth generation Dynegest. So we have various drugs available in the market, and LNG is also useful in dysmenorrhea and chronic pelvic pain. EMG implants is also useful. LNG releases 20 micrograms of progesterone in 24 hours, and it can be extended for 5 years. So the next, the synthetic progesterone is Dynegest, which is also very popular because of its anti-inflammatory, anti-angiogenic, and anti-proliferative effects. Usually a dose of 2 milligram is given. Long-term treatment is possible. But the mechanism is it inhibits prostaglandin E2. So it decreases estrogen level, inhibit vascular cell proliferation, and also angiogenesis. Inhibit cell proliferation. Because of all these properties, it has been used to reduce the disease burden of endometriosis, and various studies have documented that it can be used for a long period, even for 6 months, without major side effects. The only drug which can be used in reproductive age group when patient is thinking about her fertility also, previously all these drugs, COC, medroxyprogesterone acetate, GnRH analogs, all these drugs will cause an ovulation or sometimes pseudomenopausal state. In that way, it can reduce the symptoms. But this is the only drug which can be used in the reproductive age group when the patient wants to conceive and ovulation is not disturbed with dydrogesterone, which decreases pro-inflammatory cytokines and oxidative stress. So dydrogesterone increases progesterone receptor expression and decreases pro-inflammatory cytokines. Dydrogesterone exerts endothelial anti-inflammatory action via reduction in the expression of leukocyte adhesion molecules. So it can be given either in the form of prolonged cyclical regimen starting from day 5 to 25 or continuous regimen also. This is Arcadia study which concluded that after 6 months of its usage, chronic pelvic pain intensity is drastically reduced, and so it does not affect ovulation and does not affect serum estradiol level, induces decidual transformation with resultant necrosis and resorption of endometrial implants. So add-back therapy becomes irrelevant because it is not affecting estradiol level. So synthetic androgen danazol had been used previously either in the form of oral tablets or sometimes vaginal ring intrauterine devices. But recent evidence does not support danazol use because of its androgenic side effects and its impact on pregnancy. The recent drugs are elagolix, first GnRH antagonist, which was very popular. But add-back therapy is obviously needed when we give the drug for a prolonged period, almost 12 months. The problem with the newer drugs, antagonist, the dosage and duration of treatment is not studied extensively. The advantage is we don't have initial flare-up effect and rapidly reversible ovulation. This is a study published in Fertility Sterility 2023. Relagolix in combination with other medical treatment can be considered in patients with endometriosis. This is the comparative statement, the percentage with the 10 milligram 20% responded and 20 milligram 42% and 40 milligram 83% responded. Spirit trial 1 and 2 concluded that there is a tremendous reduction in pain score in patients with endometriosis. Aromatase inhibitors as a third line of management can also be considered in a refractory patient who is not responding to surgery or medical initial first two levels of medical management. Then the third line of management is aromatase inhibitors, either anastrozole 1 milligram or letrozole 2.5 milligram, in addition to other drugs, medical management like COC or progesterone. GnRH agonist or antagonist. Cabergoline has also been studied because it has got anti-angiogenic effect. 0.5 milligram weekly twice for 3 months had been studied in few RCTs and concluded that it has got a comparable effect to GnRH agonist. Various newer therapies had also been documented: progesterone antagonist, selective progesterone receptor modulator, estrogen receptor modulators, immunomodulators, and statin had also been tried. Progesterone antagonist for a period of 6 months, and progesterone receptor modulators had also been tried in various studies. Statin, as it reduces oxidative stress, angiogenesis, MMP, had also been studied as a medical management. TNF alpha blocker had also been studied in 2008. But the choice of treatment medical treatment depends on her symptoms and age group, and also the cost involved in it and side effect related to the drug. So when a patient is going for a surgery, it is very sure that pre-operative medical treatment is not recommended, because it is going to mask some of the lesions and the patient is going to come back with recurrence after surgery. So when you are considering medical treatment, always remember that medical management of pain usually gives a temporary response. Pain-free time is valuable and delays surgery, especially in adolescent girls. And it is helpful for patients to treat anemia and optimize fitness, and also till a time that definitive surgery is feasible. In older age group, it can be delayed till menopause, but sometimes surgery may be needed in spite of medical treatment. So let's bring an end to the endless suffering of endometriosis. Lots of literature evidence is available, but we need to think carefully. Patient-oriented drug should be selected to relieve her symptoms. Thank you so much.
Thank you, Madam Kalpana, for giving a very nice presentation about the medical management of endometriosis. And there is no doubt about the fact that newer drugs have come up and the chances of surgery will reduce over the period of time. And in young girls where the parents don't want to get the surgery done, it works very nicely. I have used in many patients and with too much of success beyond my expectation. So a medical management should always be well planned, as you have already told. It should not be used too lightly, because the person who will require surgery later on may put the surgeon into trouble, but it has a definite role. And the combination of the two drugs you have told is also very important. And what I feel, in young girls, we start with the oral contraceptive pills also, and it works in many patients very nicely. Only progesterone pills can be used. I have a patient who is using Dynogest for last 7 years. She is not willing to stop it. She is unmarried, and when I stop the drug, after 2 days she will ring, I have a severe pain. So once I tried with the other medicine, but she is not ready to stop the medicine. Every time we got all the investigation done, and it says perfect and all right, pain free. So medical management cannot be ignored. It should be given a thought of whenever required. Thank you very much for your nice presentation.
Thank you, ma'am.
Thank you, ma'am. And as we come to the end of this wonderfully enriching module, I would like to sincerely thank all our respected speakers and chairpersons for the insightful and knowledgeable session. Today's discussion really added immense value to our understanding. It was a privilege learning from all of you. Pradeep sir, do you want to add anything? Pradeep sir, Sanjeev sir, any inputs from your side?
Dr. Sanjeev, please.
No, it was a session of another great learning from the masters, and especially their personal experience really counts. So they have elaborated, all speakers have elaborated so well. Anyway, thank you, Dr. Ramani Devi, for giving us this opportunity through these wonderful webinars.
Dr. Pradeep Mitra, are you here?
I think Pradeep sir is not there. I think so. Sir, are you available?
No, we couldn't see.
I think Dr. Pradeep sir is not in the meeting right now.
So can we go to the quiz session?
Yeah, for the quiz, ma'am.
Yes.
Yeah, Jignesh, please, open the quiz and brief how to do the quiz, and Harshini ma'am will take it ahead. Jignesh, are you there?
I'm here.
Yes.
Can I start
Can
the
we start
MCQs?
the quiz? Yes, yes, please.
Okay, just give me 1 minute.
Yeah.
Are you able to see?
Yes, we are
Okay.
able to see. So can we start now?
Yes, ma'am. You can start.
What is the potential complication associated with surgical removal of adenomyoma? A. Endometrial hyperplasia. B. Adhesion formation. C. Uterine rupture. D. Ovarian cyst formation. So the answer is C. Uterine rupture. Can we go to the next MCQ? The best method of embryo transfer in adenomyosis: A. Fresh embryo transfer. B. Frozen embryo transfer. C. GnRH down regulation followed by embryo transfer. D. Depends on quality of the embryo. So last 5 seconds. The answer is C. GnRH down regulation followed by embryo transfer. Can we go to the next question? Rate of uterine rupture following adenomyomectomy: A. 6%, B. 10%, C. 1%, D. 15%. Last 5 seconds. So the answer is A. 6%. Can we go to the next question? Globular uterus is a direct sign of adenomyosis. B. Indirect sign. C. It represents size of the uterus. D. Uterus enlarges in parallel trajectory to the endometrium. The answer is B. Indirect sign. In infertility sparing surgeries, what is the optimum wall thickness one should aim for allowing conception and prevent future uterine rupture? A. 5 to 10 mm, B. 9 to 15 mm, C. 12 to 18 mm, D. greater than 20 mm. So I think the time has stopped. Okay. The answer is B. 9 to 15 mm. Next question. Which of the following may affect the embryo implantation in patients with adenomyosis? A. Increased HOXA-A10 expression, increased OPN, decreased integrin B3, D. Decreased GnRH receptors. Last 5 seconds. Decreased integrin B3. And we go to the next question. All of the following about the epidemiology of adenomyosis are true except A. Most of the previously stamped cases of DUB have been nothing but adenomyosis. Adenomyosis has been almost unknown in young women and it is still so. C. Most common cause of AUB as per palm coin classification. D. The most common histopathological diagnosis in hysterectomy specimens is adenomyosis. The last 5 seconds. The answer is B. Adenomyosis has been almost unknown in young women and it is still so. Next question. The most appropriate statement about adenomyosis is A. The most common cause of dysmenorrhea is adenomyosis. B. Combination of heavy menstrual bleeding and dysmenorrhea is almost diagnostic history of adenomyosis. C. Adenomyosis may often attain clinical size of 16 to 20 weeks. The mutual association between adenomyosis and endometriosis ranges between 20 to 30%. Last 5 seconds. The answer is B. Combination of heavy menstrual bleeding and dysmenorrhea is almost diagnostic history of adenomyosis. Go to the next question. Which of the following has no role in suspecting or diagnosing adenomyosis, at least in clinical setting? USG, B. Biomarkers, C. MRI, D. Histopathology. Last 5 seconds. The answer is B. Biomarkers. All of the following are NUSA 2015 criteria of diagnosing adenomyosis by TVS except A. Asymmetric thickening of myometrium, B. Myometrial cyst, C. Hypoechogenic islands in myometrium, D. Irregular or thickened junctional zone. Last 5 seconds. The answer is C. Hypoechogenic islands in the myometrium. The next question. The most appropriate statement about non-invasive diagnosis of adenomyosis is A. MRI has higher sensitivity and somewhat low specificity. B. TVS has high sensitivity and low specificity. C. TVS and MRI has almost similar sensitivity, which is 78 to 80%, and specificity 93%. D. The subjectivity and objectivity of TVS and MRI are almost similar. So we have last 5 seconds. C. TVS and MRI has almost similar sensitivity, which is 78 to 80%, and specificity 93%. Which of the following is a major limitation of medical therapy in endometriosis? It permanently cures infertility. B. Symptoms commonly recur after discontinuation. C. It increases ovarian reserve. D. It removes adhesions completely. Last 5 seconds. The answer is symptoms commonly recur after discontinuation. A 32-year-old woman with dysmenorrhea and diagnosed endometriosis is advised medical therapy. Which drug acts by causing decidualization and atrophy of endometrial implants? A. Letrozole, B. Dynagist, C. Clomiphene citrate, D. Tamoxifen. Last 5 seconds. The answer is B. Dynagist. A woman with endometriosis desires fertility in the near future. Which of the following medical therapies is least preferred because it suppresses ovulation? A. NSAIDs, B. Combined oral contraceptive pills, C. GnRH agonist, D. Both B and C. Last 5 seconds. The answer is both B and C. So which of the following is the mechanism of action of GnRH agonist in treatment of endometriosis? A. Direct destruction of endometrial implants. B. Continuous pituitary suppression causing hypoestrogenism. C. Progesterone receptor blockade. D. Increased LH surge. Last 5 seconds. B, continuous pituitary suppression causing hypoestrogenism. Next question. Which medical therapy for endometriosis is specifically associated with decreased bone mineral density on prolonged use? A, NSAIDs, B, Dynages, C, GnRH agonist, D, tranexamic acid. Last 5 seconds. The answer is GnRH agonist. The major challenge during adenomyomectomy is A, difficulty identifying ureters, B, excessive cervical bleeding, C, poor delineation between the disease and normal myometrium, D, tubal injury. So the last 5 seconds. The answer is C, poor delineation between diseased and normal myometrium. Next question. Which energy-based minimally invasive modality has been increasingly explored for adenomyosis treatment? A, cryotherapy of cervix, B, HIFU, high-intensity focused ultrasound, C, loop electrosurgical excision procedure, D, cold knife conization. Last 5 seconds. The answer is HIFU. Next question. During laparoscopic adenomyomectomy, the main aim of reconstruction is to A, prevent ovarian torsion, B, restore uterine integrity and reduce risk of rupture, C, improve cervical length, D, prevent urinary incontinence. Last 5 seconds. The answer is restore uterine integrity and reduce the risk of rupture. The last question. Which surgical technique is specifically described for diffuse adenomyosis excision? B, Lynch technique, triple flap method, McDonnell cerclage, and D, Manchester repair. Last 5 seconds. The answer is triple flap method. So I think Sivaranjani has got the highest score. Then next is Meenal Sarmalkar and Sudha Marwa. And congratulations for the all the other participants. Thank you so much. Nirmala ma'am, Sanjeev sir, any inputs?
It was a very nice quiz time at the end of the session. I must congratulate Dr. Ramani Devi and her team for putting such a wonderful academic session to its latest knowledge. And lastly, the quiz was also very interesting because all of us at some moment or the other had to think which is the correct answer. Thank you so much, everybody, for being here and sparing your valuable time with us.
Sir, you are under mute, sir. Sir, you are muted. You've muted yourself.
The quiz is a recap of all the talks, you know. So it's like a quick summary of all that we learned. Excellent.
Yes.
Thank you so much for today's session. Thank you. I think Ramani ma'am is being a silent moderator now. Thank you. Thank you, ma'am. Thank you, sir. Thank you for gracing the session, sir. Thank you. Thanks a lot, sir.